So a very good evening to all. Today's I'll be talking about hyperpyrexia and hypothermia, a very relevant topic as the summer has arrived and the temperatures are going up. So in this talk, I'll be focusing on physiology of thermoregulation, pathophysiology of fever, how to monitor temperature, the accurate sites, difference between hyperpyrexia and hypothermia, a detailed overview of heat-related illnesses like pathophysiology, evaluation, and their management, detailed overview of malignant hypothermia, and a bit about drug-induced hypothermia. So let us have a recap of how is body temperature regulated in humans. So as we know that we have thermoreceptors, and from there these thermoreceptors are both in the they are like peripheral as well as core thermoreceptors, which senses the change in temperature, and via afferent pathway it is brought to preoptic area of hypothalamus, and from there the efferent pathway via autonomic and behavioral responses tries to maintain the core temperature in the range of 37 plus minus zero point 0.5 degrees Celsius, that is 98.6 plus minus zero point 0.9 degree Fahrenheit. So through autonomic and behavioral responses, there are different mechanism of heat generation and different mechanism of heat dissipation, and the balance between two that finally tries to maintain the core temperature. Here we can see that there are different mechanisms of heat generation that include decreased sweating, decreased heat loss from skin, increased metabolism, and various behavioral responses like moving to a warmer climate or warmer place, covering the body uh, with more cloths or blankets. And the reverse happens when we need heat dissipating mechanisms. So let us overview the pathophysiology of fever. So this is based on cytokine and cascade hypothesis, and as we have told that the thermoregulatory center, that is hypothalamus, and there the set point that is important in sensing the temperature change, or it is the like elevation, or the set point is brought down, then the various autonomic or behavioral responses that we have talked previously. So here in fever, the hypothalamic set point is elevated during any infections or lipopolysaccharide from gram-negative bacteria. So these lipopolysaccharide molecules, they can act directly on the endothelium of hypothalamus, or they can activate the monocytes, leading to production of pyrogenic cytokines, that is interleukin 1, TNF alpha, IL-6, and they act on endothelium of hypothalamus, producing prostaglandin E2. This prostaglandin E2 binds to EP3 receptors, and after this, the neurotransmitters including cyclic AMP, they act on hypothalamic regulatory center, and there is elevation of set points. Once it is there, there is peripheral heat responses, there is conservation of more, and there is conservation of heat loss and production of more heat, and that leads to fever. So this is the cytokine hypothesis, and in addition we have a cascade of, there is a cascade hypothesis also. That is, there is a sequence of cytokines which are produced, that is TNF alpha, which induces the production of IL-1 beta, and that in turn produces IL-6. So this is the sequence of cytokines that finally acts on endothelium of hypothalamus and the upstream pathway. In addition, in patients like those have intracranial hemorrhage or intracranial injuries, they can also produce fever because of release of prostaglandin E2 from the activated platelets. So let us come to another part of this talk. What are the different sites of monitoring the temperature accurately? So We can monitor the temperature at various sites in human body. So there are certain areas or sites which actually gives an idea of core temperature, and there are sites which gives an idea of peripheral temperature. So in this slide we can see like the core temperature can be measured from the directly from the brain using a pulmonary artery catheter, from the urinary bladder, or by putting a probe or catheter into rectum, putting a probe or catheter into distal part of esophagus, while the nasopharynx measuring the temperature from the oral canal or from the axilla, that is a peripheral site. So how is core temperature different from peripheral temperature? So measuring the temperature from a core site is defined as a site which is highly perfused, and there is a uniform temperature, and it is least affected by environmental factors. So that includes our brain, uh, pulmonary blood flow, and measuring the temperature from distal part of esophagus or uh, um, bladder. So here is an overview of different sites of temperature monitoring, like brain, pulmonary artery, urinary bladder, esophagus, and all these sites they have their pros and cons. So as we can see here, measuring the temperature from brain and pulmonary artery, it is highly invasive. It needs technical expertise, and it is associated with infectious complications and other complications too. And these two sites are being considered as gold standard of core temperature monitoring. Apart from this, the putting a probe or catheter into bladder, that also gives a fair idea about the core temperature, and it has shown a reliable correlation with PA temperature monitoring. But the pitfall is it costly affair. Again, the infectious complications and urinary volume does affect the reliability of temperature. Like it is more accurate when the urine volume is high, and it becomes less and less accurate when volumes are less. For esophageal temperature monitoring, we need to put the esophageal catheter in distal one third of esophagus, and the position needs to be confirmed by a chest X-ray. And again, the pitfall is the fluid which is passing around the NG tube that can alter the temperature recording. Again, it has shown a very good correlation with PA temperature monitoring. When it comes to nasopharynx, again, it is reasonably accurate, but it can be used only in intubated patients, and the airflow around the catheter can interfere with the temperature monitoring. With putting a catheter in oral canal, so again it is difficult. The pitfall is difficult if the ear canal is tortuous, and it can cause also a lot of discomfort and pain to the patient. But the reliability or correlation with the core temperature monitoring is not very great. Coming to the rectal, the good part is it is easy to place a probe or catheter into rectum, but it may not be acceptable by many patients. It causes again a lot of discomfort, and there are certain scenarios where the temperature might not be accurate, like if there is local inflammation, there are hard feces present in the rectum, or if there is a heat producing organism in the rectum. And another potential pitfall is the core temperature. For core temperature recording, there is significant lag when there is a very rapid change in core temperature, like when we are rewarming a patient who has undergone hypothermia, or if a patient with hypothermia and there is rapid cooling, then there is a significant lag. Axillary, it is very simple to do, but again the local blood, the sweating, the local airflow, and the ambient temperature, it affects the axillary temperature recording significantly. But it is very simple to place a probe in the device in axilla and record it, and the concordance with the core temperature is not very great. So for critically ill unstable patient, it is not a good idea to measure axillary temperature. So As per the literature, for any critically unstable patients, the esophageal or urinary probes are recommended, while in hospital wards and stable critically patients, auxiliary temperature monitoring with appropriate thermometer every 4 to 6 hours is recommended. So let us come to the main topic of this talk, hyperpyrexia and hypothermia. Before that, let us have a relook at definition of fever in ICU. So as per American College of Critical Care Medicine or IDSA, the core temperature above or equal to 101 degree Fahrenheit or 38.3 degrees Celsius is considered as fever in ICU. But in neutropenic patients, a single reading of the same cutoff or a temperature of more than 100 degree Fahrenheit or 38 degrees Celsius, which is sustained for an hour with an absolute neutrophil count of less than 500 is considered fever. So, what is hyperpyrexia and hypothermia? So, in general, core temperature of more than 41.5 degree or 106 degree Fahrenheit is, it can be either hyperpyrexia or hypothermia. But the only difference is in hyperpyrexia, the hypothalamic set point is elevated, while in hypothermia, there is no alteration of hypothalamic set point. But again, it is very difficult to accept that in any kind of uh, change in body temperature that is definitely sensed by the core or peripheral thermoreceptors, there must be a change in hypothalamic set point. But why this definition is like this, I could not find a real answer or real explanation for this. To me, it feels that in any scenario when there is change in core or peripheral temperature, there must be an alteration of hypothalamic set point. But for the time being, it is the core temperature more than 41.5 degree or 106.7 degree Fahrenheit. This is called either hyperpyrexia or hypothermia with a difference in hypothalamic set point. Now let us have a look at hypothermia and hyperpyrexia in detail. So the first important point is both of these entities are usually non-infectious in origin. And if you look at hypothermia, there is a spectrum of illness called as heat-related illness. So that can be as simple as heat exhaustion, cramps, heat syncope, and in the most serious form, it can be heat stroke. In hyperpyrexia, there are different entities like drug-induced categories, which includes malignant hypothermia, neuroleptic malignant syndrome, serotonin syndrome, and anticholinergic toxicity, sympathomimetic toxicity, thyrotoxicosis, and the pheochromocytoma. So, why should we be really concerned about heat-related illnesses? So, as per literature, it has been reported that every 1 degree Celsius rise in core temperature increases mortality by 3%. And it has been reported to be top three causes of mortality in athletes. And it is predicted that the mortality is likely to increase by 2.5 folds in next 30 years. And another important fact to consider here is that heat stroke causes multi-organ dysfunction and the mortality can go as high as 80% if it remains untreated. And it is not uncommon to see these newsprints appearing on the front page of newspapers when the summer arises and the temperature starts going up, where the reports of people getting affected, having affected by heat waves and getting admitted to hospital and rise in overall deaths or mortality. So this is a concern in every summer, and with rising global temperature because of global warming, deforestation, urbanization, and other factors, it is expected that we'll be witnessing more cases of heatwave affected patients or individuals in coming years. So that is why We need to be really worried about heat-related illnesses. We need to have in-depth knowledge, the pathophysiology of heat-related illnesses, how to diagnose them, and how to manage them in the hospital setup. So let us have a look at different entities of heat-related illnesses. The most severe form is heat stroke. We'll be talking more in detail about this, where there is core temperature is more than 40 degrees Celsius with sinus dysfunction. Heat exhaustion is nothing but it is the fatigue or diminished physical activity in heat due to salt and water depletion. Syncope is dizziness or fainting because of volume depletion and postural pulling in lower extremities, while cramp is painful muscle cramps during exercise and heat because of fluid and electrolyte depletion. So coming to definition of heat stroke, uh, it requires three components: the core temperature, and in heat stroke, it is recommended to measure the rectal temperature. It should be more than 40 degrees Celsius, along with CNS dysfunction that includes delirium, convulsions, coma, and multi-organ dysfunction. So this definition was given by Bochama et al. In 2002. The another society, that is Japanese Association of Acute Medicine, they give a slightly different criteria that includes CNS dysfunction, similar to the definition given by Chama et al., DIC, hepatic and renal injury, and exposure to heat. The difference is they do not include the core temperature here, while the original definition includes a temperature cutoff of more than 40 degrees Celsius. But it is important to consider here that we should not be very strict to this temperature cutoff, because when a patient has been exposed to excessive heat in the outside hospital setup, once from there he is being shifted to the hospital, some cooling might have occurred and we might not be able to get this temperature cutoff. But if there is a exposure to heat and the other criteria are met, we should consider heat stroke into our diagnostic algorithm. So heat stroke has been classified as of two types. One is classical heat stroke and another is exertional heat stroke. The classical heat stroke, that is occurs in elderly or pre-pubertal children, and it occurs because of passive heat exposure with poor heat dissipation mechanism. And in this classical stroke, usually the ambient temperature is very high. While in exertional heat stroke, it usually occurs in young individuals, and there is excessive heat production from skeletal muscle activity, and many a times the ambient temperature it may be normal. And here we can see the athletes, the military personnel, the firearm workers, and the construction site workers. These are the susceptible group of individuals who can present with exertional heat stroke. So what are the risk factors for heat stroke? And we have extrinsic factors, intrinsic factors, and certain medications. So again, from extrinsic causes, we have like hot and humid condition, heat waves, inappropriate clothing. For intrinsic causes, any factor which leads to poor heat dissipating mechanisms, like patient with low physical activity, patients with diabetic neuropathy, skin disorders, sickle cell disease, extremes of age, poor hydration status. So, so all these factors lead to poor heat dissipation, or patients who have impaired sweating mechanism. There are a lot of drugs which can actually predispose an individual to heat illness. So we can see here a lot of drugs that includes like alcohol, sympathomimetic drugs, anticholinergics. We have CCBs, beta blockers, diuretics. So all the drugs, they have they actually act directly or indirectly impairing the heat dissipating mechanism and put the individual at risk of developing heat illness. So, how to recognize clinically the heat stroke? So, as I mentioned previously, it is a multi-organ, it is a multi-system disease, and it can involve from head to toe, including CNS, pulmonary, cardiac, liver, renal, gut. So correspondingly, we can have different system, like different sign and symptoms. For example, in CNS, the patient can present with confusion, seizures, coma. From pulmonary point of view, the patient can present with SOB, hypoxemia that can later on leads to ARDS. From GI point of view, patient can have nausea, vomiting, intestinal ischemia, and there is increased risk of bacterial translocation from the intestine. For cardiovascular, they can have tachycardia, rhythm disturbances, hyper or hypodynamic cardiac output, myocardial injury. They can have hepatic injury. From renal point of view, they can have like acute kidney injury, rhabdomyolysis, and coagulation disturbances. So, what is the pathophysiology of heat stroke? So, at a cellular level, a high temperature leads to damage to mitochondria, DNA, protein, stimulation of excitotoxic mechanisms that leads to local effect in terms of edema, inflammatory changes. There is vascular damage and cytokine release. And when it comes to systemic effects, there is endotoxemia, and as I mentioned previously, on gut there can be a translocation of bacteria from the gut into systemic circulation, and that can lead to septicemia. And as I mentioned that CNS dysfunction as one of the core criteria of defining heat stroke, there is increased blood-brain permeability, there is decreased cellular oxygen and glucose uptake, and there is a decline in blood flow. Initially, because of rise in temperature, the cerebral metabolism increases, and for flow metabolism coupling, the cerebral blood flow also increases. But later on, when at cellular level, this the cellular machinery is damaged, the metabolism actually decreases, and there is decline in cerebral blood flow. So, how to evaluate and manage the patient with heat stroke? So, again, it starts with very basic ABC, that is checking airway and breathing, then focusing on hydration status, giving volume resuscitation, checking the rectal temperature, and we have to institute the cooling methods as early at the earliest possible. And we definitely need to rule out the alternative possibility of raised body temperature or patients who have like mimicking a heat stroke. We order for laboratory test, and we have to monitor the patient for metabolic complication and end organ failure. Again, we need to have continuous monitoring of core temperature. Sorry. Continuous monitoring of core temperature, continuous monitoring of cardiovascular, respiratory, renal system, renal and CNS. We need to monitor the oxygen saturation by using a pulse oximeter. But the important point is here, when we are measuring oxygen level using a pulse oximeter and we are doing and looking at oxygen level in arterial blood, because of increased temperature, there is shift in oxygen dissociation curve to the right, and the what we can observe that despite having adequate oxygen content in blood, there will be disconcordance in the oxygen level being measured by pulse oximeter, and that one being shown by the arterial blood gas analysis. So as we know that with rising temperature, the oxygen dissociation curve shifts to the right. So what will happen that your partial pressure of oxygen will, despite being adequate, the oxygenated hemoglobin content will become less, and that is why your SaO2 will decrease. So we may have a good PaO2 in the blood, but the oxygenated hemoglobin content will be less, and in pulse oximeter it may show a hypoxemia or desaturation. Again, from laboratory point of view, we need to order CBC, we need to order electrolytes, LFT, serum osmolarity. We look at muscle enzymes, especially creatine kinase. We need to look at clotting parameters, and definitely we need to look at urine for myoglobin and other casts. So let us come to managing a patient with heat stroke. So apart from continuous monitoring of CNS, cardiac, respiratory, renal, and temperature monitoring, the most important part is institute physical cooling as early as possible. And it has been shown that it is the most effective intervention in patients with heat stroke, and it is it has shown that cooling rates of greater than 0.15 degrees Celsius per minute, it reduces mortality in patients with exertional heat stroke, while rapidly cooling an individual with heat stroke below 38.9 degree, it decreases mortality in classical heat stroke. Apart from physical cooling, we'll have more detailed talk on physical cooling in coming slides. We need to have supportive therapy like fluid resuscitation, electrolyte management, and managing the complications like seizures, arrhythmias, rhabdomyolysis, AKI, disseminated intravascular coagulation, and hepatic dysfunction. When it comes to pharmacological treatment, there is no established pharmacological treatment for heat stroke. And if you use acetaminophen or antacids for decreasing temperature, it actually worsens AKI, hepatic failure, and DIC. So no pharmacological treatment is recommended, and we should avoid giving these agents in patients with heat stroke. So let us come to physical cooling techniques. So here we can see a ladder of different physical cooling techniques, and the techniques which lower the temperature at less than 0.7 degrees Celsius per minute, they are considered really ineffective or inadequate. Those who have ability to decrease the core temperature by 0.07 to 0.15 degrees Celsius per minute, they are considered adequate. And the techniques which have ability to lower down the temperature by more than 0.15 degrees Celsius per minute, they are actually ideal techniques. So here we can see that using of cooling blankets or gastric covers, they are really ineffective. In adequate measures, we have cold IV fluids, wet towels, ice packs, helicopter drawn draft with water and temperature water and fan. While ice sheets, cold water immersion or ice water immersions, they are actually ideal. So when it comes to which fluid we should consider while cooling the patient through IV infusion, so should we use normal saline or balanced salt solutions? So theoretically normal saline looks a better option, because in sweating, when there is in a patient with heat stroke, there is loss of sodium and chloride via sweat. But again, which one is optimal, like normal saline or balanced salt solution? We need prospective trials. So there is a significant amount of evidence and available literature which suggests that ice water immersion is the most effective technique of rapidly bringing down the core temperature to the desired target. And it has been suggested that the ice water should have a temperature ranging from 1 to 70 degrees Celsius. But while putting a patient in ice water tub and cooling the patient, it has a great advantage in terms of bringing the core temperature to a below to a target temperature. But there are scenarios where not a it becomes actually difficult to manage the patient with ice water immersion in scenarios like when patient has a compromised airway and we need to secure the airway, if the patient is throwing seizures, having arrhythmias, and there is a need for IV fluid administration. So in all this scenario, these techniques, it becomes very difficult to use and implement. So during physical cooling, again we need to brought down the core temperature to a target temperature immediately. For that, it has been advised to use rectal temperature. And suppose we don't have a rectal thermometer available with us, then how we are going to target the cooling technique? Like how we are going to titrate, when to stop the cooling, and how long we should continue the cooling. So clinically, what we are supposed to do that cool the patient until the patient starts shivering. This is the one. Or treat the patient with cold water immersion for 15 to 20 minutes. And it has been seen that cooling for this much duration usually brings down the temperature 3 to 4 degrees Celsius low. And by this time, we can actually take the patient out of ice tub. So, having a detailed discussion on different physical cooling techniques and uh, ice water immersion, does dantrolene has a role in treating patient with heat stroke? So there are few literature available which suggests that dantrolene actually accelerates cooling in exhaustional heat stroke. It attenuates severity of exhaustional heat stroke in animal model. So why it is so? So in terms of genetic analysis, like the individuals who experiences muscle cramps or easy fatigability during exercise in excessive heat conditions, those patients were prospectively followed up, and they found that the mutations in skeletal muscles, that is regulating the calcium release, so there was some overlap between the genetic abnormality seen in the malignant hypothermia and the patients who experience exertional heat stroke. So that is why, because of the overlap in genetic mechanism or the mutations which are common to both the categories, that is exertional patients with exertional heat stroke and the patients with malignant hypothermia, dantrolene has found to be working or effective in patients with EHS. Now, there is a literature in patients who experience exertional heat stroke and the type of muscle fiber in their skeletal muscles. So, as we know, in humans, we have three types of skeletal muscle fibers. That is, one is type 1, which is slow oxidative. Type 2, in that we have type 2A and type 2B. So, type 1 and type 2, they are they have predominantly aerobic uh, metabolism, while type 2B has anaerobic metabolism. And these two group of muscles, they have high resistance to fatigue. That means they don't fatigue easily. And these muscles are good for endurance and posture activity, while type 2B muscles, which have predominantly anaerobic metabolism, and they are very less resistance to fatigability. Like that means they will fatigue very easily during intense exercise. So it has been found that the patients who have suffered from exertional heat stroke, they had predominantly type 2 B fibers, and that is why these patients experienced a exertional heat stroke, increased blood lactate level. So coming to the prognosis and follow-up of patients with heat stroke. So what are the different poor prognostic markers of patients with heat stroke? So here the cooling rate. Suppose we have a patient with heat stroke, how early we institute the cooling therapy and bring down the core temperature to a set target. So that time gap is very very important with respect to prognosis. So when there is a delay of more than an hour in instituting the cooling therapy and bringing down the core temperature, it leads to poor prognosis. And it has been seen that mortality approaches almost zero when temperature is brought less than 40 degrees Celsius within 30 minutes. The ambient temperature also decides the outcome. Like in patients with exertional heat stroke, those who have been ambient temperature more than 41.5 degrees Celsius, they have higher mortality. And in patients with classical heat stroke, a core temperature of more than 40 degrees Celsius. There is a scoring system that is called J-Rato score. So initially, this scoring was developed in Japanese cohort in 2018 on around 3,000 individuals, and this scoring actually predicts at hospital admission using 6 variables, and they are being given a score of 1 to each parameter. So as the score increases, or a individual with higher score at the time of admission, they have a they have higher chance of having hospital admission, ICU admission, or overall mortality. So in J-Rato score there are 6 variables, that is age, respiratory rate, GCS, systolic blood pressure, heart rate, and temperature. And what they have found that a cutoff of 5 has a sensitivity and a specificity of mortality, has a specificity for mortality around 74 and 64% respectively. If heat exposure to heat leads to burns, so patients with higher percentage of burn leads to higher mortality. And again, patients with organ failure and DIC, again they have higher mortality. So coming to the long-term follow-up, like we have a patient with stroke who survive heat stroke who survives, and later on being followed up. So it has been seen that many of the patients, they have persistent neurological dysfunction in terms of cognition, memory, and some patients may have seizures in long term. Apart from this, central pontine myelinosis and GBS has been reported in long term in patients who have suffered with heat stroke. In CNS, cerebellum is the most common site to be affected. Apart from it, your hypothalamus can get affected. And here is an MRI in patients during follow-up, and this patient who developed actually cerebral atrophy. Here we can see that cerebellum is smaller in size, and later on follow-up, it has almost become negligible. In cardiovascular patients, in long term, they can have ischemic heart disease, they can develop MI, or they can also develop heart failure. Now, let us come to malignant hypothermia. This is one of the entity that is rarely reported rarely seen, but important to talk about. So it is dr- one of the entity coming under the umbrella of drug-induced hypothermia. Malignant hypothermia, it is also known as malignant hyperpyrexia, hypothermia of anesthesia, and it also comes in category of orphan disease. It has given a nomenclature here. So the overall incidence ranges 1 in 10,000 to 1 in 250,000, while the genetic susceptibility, it is 1 in 3,000 to 1 in 8,500 individuals. So if you see here, the genetic susceptibility is more frequent, while the clinical presentation is not that frequent. So here we can see that the 1 in 3,000 to 8,500 individuals, they have a genetic uh, susceptibility, but the clinical but the incidence, the actual, we encounter a patient with malignant hypothermia, it is not that frequent. That means all the patients who have genetic susceptibility or have genetic mutation corresponding to malignant hypothermia, that is actually not expressed, and that is called incomplete penetrance. That means we have a gene which is mutated and responsible for malignant hypothermia that is present in an individual, but that is not getting expressed. So that is why we have a genetic susceptibility in which is seen in lesser this proportion, the genetic susceptibility and than the real incidence. So there is a lot of difference because of uh, that depends upon where the genes which is present is expressed or not. Coming to the inheritance pattern, it is autosomal dominant. Males are more affected than females, and half of the cases are seen under age of 15. So coming to the risk factors, um, individuals with pharmacogenetic disorders, and the most common uh, genes which is affected is ryanodine receptors. So genes for ryanodine receptor, dihydropyridine receptors, and another uh, calcium channel, that is CACNAS1. Patients with inherited myopathies like central core diseases, multi-mini core disease, nuclear myopathy, and King-Dannebrog syndrome. When any individual with this pharmacogenetic disorder or myopathy is exposed to triggers, including inhaled anesthetics or a depolarizing muscle relaxant, that is succinylcholine, or in few cases vigorous exercise and heat, leads to hypermetabolic crisis. So apart from patients who can develop malignant hypothermia in perioperative period, it has been seen that uh, it usually develops within 1 hour of exposure to inhaled anesthetics or depolarizing muscle relaxant. So if you are seeing a malignant hypothermia, if you see features suggestive of malignant hypothermia after 1 hour of last exposure to inhaled anesthetics or other triggering agents, we need to consider the alternative diagnosis. Apart from perioperative period, patients in ICU, they can also have malignant hypothermia. This is one of the case report which was reported in 59-year-old male patients who was exposed to uh, sevoflurane during ICU sedation. Now, as all of us know that we have a device that is known as Anaconda, which is being used to provide inhaled sedation in ICU patients, and this practice is becoming more common now, and that is why we need to be aware that even patients in ICU who are being given inhaled anesthetics, there is a high possibility in patients who have genetic susceptibility and we can encounter malignant hypothermia in them. So what is the pathophysiology? How does it happen? So whenever susceptible individual is exposed to the different triggers which were mentioned previously, there is uncontrolled release of calcium from sarcoplasmic reticulum. So as we know that the ryanodine receptor is the most common calcium channel that is being affected in patients with MH. So there is uncontrolled release of sarcoplasmic reticulum into the cytoplasm, and also added to it there is defective uptake of calcium from cytoplasm into sarcoplasmic reticulum. This excessive calcium causes increased uh, contraction of muscle filaments that indirectly leads to increased mitochondrial oxygen consumption, and after a certain point the muscle switches from aerobic metabolism to anaerobic metabolism. Then there is increased glycogen cleavage to lactate. This finally results into heat production, rigidity because of excessive muscle contraction, and because of anaerobic metabolism there is lactate production and acidosis. So, and later on talk about dantrolene, which is being used for treating malignant hypothermia, that actually blocks this, that acts on these ryanodine receptors and blocks the release of calcium from sarcoplasmic reticulum. So how to recognize malignant hypothermia clinically? So during a perioperative period, the earliest time is a sinus tachycardia. We have a rising end-tidal carbon dioxide despite optimization of minute ventilation, muscle rigidity. If you have a continuous temperature monitoring during anesthesia or perioperative period, we can see a rising temperature. And that temperature rise usually occurs at the rate of 1 to 2 degrees Celsius every minute. In addition, patients, if we do an ABG, will see hyperkalemia. Uh, because of rhabdomyolysis, we can encounter a red-colored or cola-colored urine. Uh, we can have acute kidney injury. We can have disseminated intravascular coagulation. Because of the sympathetic surge, we can have congestive heart failure, bowel ischemia, and because of muscle necrosis, we can have muscle edema and compartment syndrome. So we have a clinical grading scale to predict how susceptible or how likely is malignant hypothermia when we have like clinical sign and symptoms corresponding to malignant hypothermia. And this was developed by Lara et al. In 1994, and it includes actually 6 parameters. So we have a rigidity, and in each category there are different defining cutoffs or criteria, and they are given certain points. So like in rigidity, where there is generalized muscular rigidity without shivering or spasm of masseter muscle after succinylcholine choline administration, so they have given 15 points each. So there is another category, muscle breakdown, which and we have a objective parameter to measure the muscle breakdown, like measuring the creatine kinase, urine myoglobin, or hyperkalemia. Again, they are given different points. For respiratory acidosis, when we are measuring the end-tidal CO2, or we are measuring PaCO2 in blood, then again they're given certain points for temperature increase. Then we have for cardiac involvement and other parameters. So we can see there are like different categories: rigidity, muscle breakdown, cardiac, respiratory involvement, then temperature, and others. And when we take the score from different categories and sum it up, and we calculate the total points. So here we can see that uh, once the points are 20 and above, the likelihood of malignant hypothermia is somewhat greater than it could be likely, and moment it is 50 and above, it is uh, it is highly it is almost certain that MH is the diagnosis. So how we manage patients with malignant hypothermia? So as we know that the triggering agent, which is inhaled anesthetic agent or succinylcholine. So if you are using inhaled anesthetic agent, we have to stop it immediately. And if there was exposure to succinylcholine, we'll avoid further exposure to it. There will be rise in CO2, so we need to increase the minute ventilation to lower down the CO2, and we need to call for help. And we have to prepare and give dantrolene in the doses of 2.5 mg per kg, and it has to be repeated every 10 to 15 minutes till your acidosis, pyrexia, and muscle rigidity start resolving. Because of hypothermia, we need to institute cooling measures as early as possible, because we know that higher temperature will lead to tissue destruction. So using ice packs or cold IV fluids and or more aggressive measures, whatever available at a institute, we can they're supposed to use that. And moment the temperature reaches below 38.5, we have to stop cooling. If there is arrhythmia, amiodarone or lignocaine to be used, and it is advisable not to give calcium channel blockers. So there are few literatures which suggest that calcium channel blockers, at least in animal models, been shown to increase um, has been shown to increase the calcium level in the cytoplasm of skeletal muscles. So we don't have enough literature about it, but in animal models and using calcium channel blockers like nifedipine, they have found that it increases the intracytoplasmic calcium concentration. And as we know that in MS there is already a lot of calcium in the or uncontrolled release of calcium into cytoplasm from sarcoplasmic reticulum, and we should not add to that insult. Immediately uh, we need to have a blood gas analysis to look at acidosis, hyperkalemia, or rising lactate. We need to monitor the electrolytes, importantly potassium, to rule out the muscle injury. We need to send creatine kinase and blood endocrine for myoglobin. So dantrolene has to be continued, as I talked previously. And if during treatment, if we find that the dantrolene dose is exceeding more than 10 mg per kg, then we have to consider then diagnosis of MH is unlikely. So doses up to 10 mg per kg and symptoms starts resolving, then it's okay. But if you start giving dantrolene and the dosage exceed more than 10 mg per kg, still the symptoms are persisting, that means you have to reconsider the diagnosis of MH. We need to ensure urine output on the higher side using IV fluids or diuretics, so that to avoid pigment induced renal injury. And we need to evaluate whether there is a need for invasive monitoring or continued mechanical ventilation or not. And in intensive care unit, observe the patient at least for 24 hours, but preferably for 48 to 72 hours. And once it has happened, MH has been established, we need to evaluate the patients and their family in future, uh, in so that we can rule out the genetic susceptibility in other family members of the patient, and so that in future and we can avoid MH in susceptible individual. So how do we test for malignant hyperthermia? The gold standard being the in vitro contracture test. So what is done here, that we take a muscle biopsy and we look for contraction of muscle fiber in presence of halothane or caffeine. And there are two groups. One is European malignant hypothermia group, and there is another, that is North America malignant hypothermia group, and both of them they suggested to use halothane or caffeine. But only difference in their diagnostic criteria is that the concentration of halothane or caffeine, that is a bit different in both the groups. But when a patient shows when the muscle fiber shows contraction to both halothane and caffeine, the individual is considered to be a malignant hyperthermia susceptible, that is MS susceptible. And if the results are negative, like there is no contraction with exposure to both halothane and caffeine, and they are called MH non-susceptible. So there are certain individuals where muscle contraction can be seen with exposure to halothane but not to caffeine. In certain individuals, contraction to caffeine can be seen but not to halothane. So those patients are called MHS, but in bracket we have to put H, or in MHS bracket C. That is malignant hypothermia susceptible only to halothane or only to caffeine. So out of this two group of individuals, when this testing was uh, compared with their genetic testings, like in muscles biopsy, and the actual genetic makeup and the mutations for MH were looked at, what they found that the concordance between MHS individuals who were positive for caffeine, there was more concordance compared to the individuals who are MHS, but they have shown positive contraction with halothane. So that means if the individual has positive contraction with caffeine, that is likely to have a corresponding genetic mutation. So as I have told that the in vitro contracture test is the gold standard, but genetic testing is not. So the reason being, there are lots of mutation for ryanodine receptor or dihydropyridine receptors, and it's really difficult to look for all the mutations because it is too expensive. It is not widely available, and another reason is that there is incomplete penetrance. That means, suppose I find the patient is having mutation corresponding to MH, but whether that mutation is actually expressed or whether it will be expressed phenotypically when that individual in future is going to be exposed to trigger agents like inhaled anesthetic or succinylcholine. So that is the drawback of doing genetic testing. But here, if I am taking a biopsy of a skeletal muscle and exposing to halothane or caffeine, and there is a positive contracture test, that means this patient or individual is likely to have malignant hypothermia, and the patient will definitely develop MH if exposed to the triggering agents. So that is why the gold standard is IVCT, not the genetic testing. So how to prevent MH? So once we have witnessed a patient with uh, MH, and we have identified any member in the family which is MH susceptible, then that patient should be correctly identified, and a record should be maintained that should be available nationwide, so that any person can access and have a details of that individual from the database. So it is very important to have preoperative assessment and identification of that association with a known family. And patients with any form of muscle disorder, we should avoid giving succinylcholine. And again, I told that there are certain myopathies that I mentioned previously. They are also have a potential to manifest damage if they are exposed to the triggering agents. And it is advisable not to give succinylcholine in any young patients below 12 years of age, because many of them they might have undiagnosed muscular dystrophies, and they can develop MH. So now coming to other drug induced hypothermia, categories apart from MH. So in drug-induced hypothermia, the core temperature is at least 38.3 degrees Celsius. And importantly, this hypothermia is unresponsive to antipyretics. And in addition, this drug-induced hypothermia may get complicated by rhabdomyolysis, multi-organ failure, and DIC. And what are the different mechanisms by which the drugs induces hypothermia? So the drugs can cause hypothermia by altering the hypothalamic pituitary adrenal axis. It can be idiosyncratic reactions, or it can be immunologic or hypersensitivity reaction. So these are the different syndromes which we'll be talking in brief, like neuroleptic malignant syndrome, serotonin toxicity, anticholinergic toxicity, sympathomimetic syndrome, MH that I have talked in detail, and there can be uncoupling of oxidative phosphorylation like phosphorylation in salicylate overdose, or when patient is exposed to dinitrophenol. So this here we here is a comparative table of these different syndromes like neuroleptic malignant syndrome, serotonin toxicity, anticholinergic toxicity, sympathomimetic syndrome. So in all these syndromes, there is significant overlap in terms of like autonomic instability, CNS involvement, motor system involvement, or other features. But if you see the onset, the neuroleptic malignant syndrome has a slow onset compared to the other syndromes. So this is the one uh, way how to differentiate NMS from other drug-induced hypothermia. So apart from onset, they have significant autonomic system involvement like hypertension, tachycardia, and there is significant mental status like CNS involvement, including confusion, restlessness, or coma. If you look at and also and uh, compared to other syndromes, NMS has significant rhabdomyolysis. So that is why measuring creatine kinase, and if you see a very high level of creatine kinase along with other um, clinical parameters, along with exposure to a triggering agent, then NMS is a high possibility. In serotonin syndrome, again, they can have a, like autonomic system involvement, CNS involvement, but important to identify that they have a hyperreflexia, and we see clonus. So in serotonin syndrome, if clonus is a significant or identifying uh, feature. In anticholinergic, again, there will be symptoms corresponding to cholinergic axis. So, like there will be loss of sweating, so there will be no diaphoresis, and if it's the other symptoms of cholinergic axis, like we'll see mydriasis, we'll see constipation, urinary retention. In sympathetomimetic, there'll be like just opposite to the anticholinergic axis, and we have a triggering agent. So we'll see everything like mydriasis. We see increased gut movement. We see more uh, autonomic disturbances, like in terms of hypertension, tachycardia. So all the features of sympathetomimetic source. So how do you manage these different drug-induced syndromes? So to common to all of them is the very basic ABC, cooling the patients if there is hypothermia, using IV fluids, electrolyte management, thromboprophylaxis, and monitoring them from risk of aspiration. If there is a muscle rigidity and agitation, we need to use the benzodiazepines judiciously. And I would like to emphasize again that antipyretics, they are really ineffective in managing fever or raised temperature in these patients. In NMS, if there is moderate rigidity and hypothermia, we can use bromocriptine, which is agonist to dopamine type 2 receptors. And if there is severe rigidity, there are case reports where we can use dandrolene. Serotonin syndrome, we can use chlorpromazine or cyproheptadine, that is 5 S2A serotonin receptor antagonist. In anticholinergic toxicity, we can reverse by using fugiostigmine. And in sympathomimetic toxicity, this is all supportive and removing the offending agent. Now, the last part of my talk, it is about dexmedetomidine induced hypothermia. Since as an intensivist, we are using different types of drugs to sedate the patients in ICU patients. And dexmedetomidine is getting in popularity these days. So we should be aware about the one of the adverse side effect of this drug. So as we can see that there are lots of case series, case reports, and retrospective data which suggests that dexmed can cause hypothermia. So the incidence has been reported to be 1 to 10%, and there were two trials, Midex and Prodex trial, which reported uh, dexmedetomidine related hypothermia as an adverse effect in around 5 to 6% patients, and it usually occurs 3 to 24 hours of initiation of dexmed and resolves after 2 to 12 hours of discontinuation. So this is a important drug because now it is being increasingly used in ICUs for sedation, and we should be aware if there is a rising temperature and we have ruled out other infectious or non-infectious cause of rising temperature by appropriately investigating the patient using like blood cultures, looking at other blood parameters, imaging. So this is one of the category that must be kept in mind, and we should be aware of it. Thank you.